I'm Dr. Arnold Wheel, and I practice in Atlanta, Georgia. I have a non-surgical orthopedic practice and also specialize in pain management. Today I'm going to be talking about disability assessment and impairment and disability evaluations. Impairment is defined as a deviation from normal in a body part or organ system and its functioning. Conditions that interfere with activities of daily living are an impairment. Impairments can be defined as temporary or permanent. And a permanent impairment is one that's unlikely to change in spite of further medical or surgical therapy. Impairments are typically given as a percentage, and this percentage comes from the guides to the evaluation of permanent impairment. It's referenced typically as either a partial impairment, total impairment, a temporary, or permanent impairment. A disability is different. A disability is defined as an alteration of an individual's capacity to meet personal, social, or occupational demands because of an impairment. This is typically a restriction or lack of an ability to perform an activity in the manner considered normal for a particular individual. So whereas an impairment would be the loss of ability of a body part to do something, the disability is what that individual cannot do because of his or her impairment. A handicap is really an impairment that substantially limits one or more of life's activities. So a person needs to compensate in order to perform that activity. So somebody who's handicapped is unable to do a particular type of activity that they may want to do, and then has developed a compensation mechanism in order to allow them to do that particular activity. The Guides to the Evaluation of Permanent Impairment is a standard text for impairment and disability evaluations. Currently, we utilize the 5th edition, although new editions may come out at some point. What we do is we take charts and tables that are referenced in the guides, and we plug in certain numerical values based upon an examination of the patient to get objective, not subjective, data and ratings. The guides, as the standard utilized text, is objective, it's authoritative, and it's widely used by all physicians who perform impairment and disability evaluations. So the structure and use of the guides, again, this is the medical assessment of impairment. And the criteria includes reviewing office and hospital records, history taking from the patient, and again, the judicious use of diagnostic tests when available and when necessary. And then finally, the physical examination. These are the components that we utilize to obtain a rating based upon the guides to the evaluation of permanent impairment. So what are the rules for the evaluations? Well, we need to estimate the extent of the patient's primary impairment. We use tests of consistency to validate that we're getting a consistent effort from the patient. We use the combined values chart in the text, again, to get the actual numerical value for the impairment rating. And we obtain measurements. Sometimes we take into account pain as a variable, and again, adjustments for the effects of treatment or lack of treatment. So these are all part of what we utilize within the guides to obtain an appropriate rating for impairment and disability. Records and reports. Again, the medical evaluation. We perform an evaluation of all the medical records, take the history from the patient, and then we dictate and perform a narrative history outlining everything from the initial injury to the processes that brought about the injury, mechanism of injury, to what's occurred during the treatment period of time, and what the patient is complaining of today, and where we are in this process. The discussion of diagnostic testing is also utilized, again, in any prior treatment. All these are referenced in our report for an impairment and disability evaluation. At that point, then, we analyze the findings. We try to incorporate everything that we have uncovered through history and review. And after analyzing the findings and taking measurements in our physical exam, we obtain the percentage of impairment criteria from the guides and the chart. And as I mentioned before, they are objective. It's not a subjective part of my part. And again, any impairment rating should be consistent from one physician to the next. So if we go through and look at the various types of impairment ratings we can do, we'll start off with the musculoskeletal system. Here we can look at and evaluate the upper extremity, lower extremity, spine, and pelvis. And each of these areas are looked at as a unit of the whole person. So when we assign an impairment rating, it's an impairment of, let's say, the spine as a relation to whole body. But it's much more pertinent to give each impairment for the particular body part. It makes much more sense, and it's relevant as far as applying the appropriate disability. So let's start off with the upper extremity. Again, looking at impairments, we're going to evaluate the upper extremity from the hand, wrist, elbow, and shoulder. We take each body part, we look at range of motion. If the motion and movement is within full range of motion, looking at flexion, extension, abduction, adduction, internal rotation, external rotation. And we go back to the book, to the guides, to see what the normal values are and what the values are for the particular patient. Lower extremity, very similar. Again, looking at foot, hind foot, ankle, leg, knee, hip, all the joints of the lower extremity. Again, each time we do an impairment rating, we must take measurements of each joint in that particular extremity that we are assessing. The spine is another area where we commonly are asked to do assessments for an impairment and disability evaluation. So again, the spine we break up into the individual segments of the spine, whether it be cervical, thoracic, or lumbar. And of course, in the lumbar spine, we closely assess the coccyx and sacral areas as well. So again, each impairment rating, each time we do a rating, we're taking the particular area of the body. In this example, the spine, we're measuring range of motion. If we're doing cervical spine, we measure flexion, extension, rotation to the right, rotation to the left. Okay? We compare the measured values to the norm. We can use goniometers, we can use inclinometers, we can use range of motion assessments, but nonetheless, we have to obtain the reproducible numerical value and compare this to the norm. Pelvis, again, looking at pubis, ischium, and ilium, and again, assigning appropriate impairment ratings based upon the guides to the evaluation of impairment. So how do we do that? Well, I've mentioned before we obtain range of motion values, but certainly it starts with a cosmetic evaluation. We visualize the particular impairment. We look at the body part, see, document, and state what we see on our exam. And then we do a functional evaluation as well. The use of the body part. Are they able to use that arm to dress? Are they able to use that arm to feed themselves? All right? So the most practical and useful approach to evaluating any type of digit impairment is to compare it with a loss of function that results from an amputation. That's really where the guides take their origin from. Looking at an amputation, if that existed, and the loss of function associated with that. So in the musculoskeletal examination, we look at restriction of motion, whether the active motion takes precedence over the passive motion. In other words, if the patient cannot move their arm and flex their elbow themselves, can the examiner, can the physician do it and move that joint passively? Again, the range of motion measurements are rounded to the nearest 10%. And we go back to the guides specifically look at range of motion in percentages. So again, if my range of motion is 37, but the guides mentions 30 and 40, I'm going to round it to the 40% or 40 degrees. Okay? And as I mentioned, often we can measure the range of motion and movement with a goniometer. All right? So the musculoskeletal examination then is going to look at range of motion, sensory loss, and again, the abnormal motion that we find on exam is going to equal the percentage of impairment for that particular body part. So the range of motion then that we obtain is measured and compared to the graphs and the guides, and the percent loss is determined from the tables and then reported in our evaluation report as an impairment rating percentage. So in looking at the reporting of impairments, the regional impairments are combined to obtain impairment of the whole person. So for example, if I have a patient with a neck injury and a low back injury, I'm going to assess and obtain an individual impairment of the neck, and then I'm going to assess and obtain an individual impairment of the lumbar spine, and then I'm going to combine these through charts in the impairments guide to obtain and get to the impairment of the whole person. So I will determine each impairment of each region, such as the hand or the wrist or the elbow or parts of the spine. I'll use the combined values chart then to combine these impairments and use tables to convert the impairments of the upper extremity in this particular case to the whole person. So it's very important if you are requesting your physician to obtain an impairment rating to specify whether you want an impairment of the particular body part, i.e. impairment of the lumbar spine, or whether you're more interested in an impairment of the whole person. So how that impairment of the spine relates to the whole person. For example, if somebody has a very significant impairment of the elbow, and their impairment of the elbow is on the order of 30%, that may be only a 5 or 7% impairment of the whole body or the whole person. So it depends upon what you're particularly looking at into what we provide for you as part of our impairment rating. Most of the time we're asked to assess and provide an impairment rating for a particular body part and not convert it to the whole person. Well, there are certainly other factors to consider when performing an impairment rating, and in this case, in addition to obtaining range of motion. So if you look at the lower extremity in particular, there are other factors we might consider. For example, is there limb length discrepancy? Is one limb longer or shorter than the other? Is there abnormality in gait? Okay, is there muscle atrophy that we can see on the evaluation and part of our examination? All these things may affect the impairment, and although they are more subjective, they still can be used to integrate into our impairment rating. Again, manual muscle testing is used to determine strength. Peripheral nerve injuries may be documented, and sometimes we'll do a nerve conduction study to evaluate for peripheral nerve injuries. And also vascular disorders can certainly contribute and be added in and considered in addition to range of motion for impairment of the lower extremity. And finally, pain. Sometimes pain is used to, again, help us with our assessment of impairment based upon the particular injury and body part. So let's talk about spine disorders. Again, spine disorders is a little different as far as our impairment. We use diagnoses-related estimates, and there are 8 categories that we look at. What we do is we look at the different categories to determine what our impairment rating may be. In the cervical and lumbar spine, the diagnosis-related estimates, or DRE, are labeled 1 through 8. Okay? And there's a maximum whole person impairment by spine region. So for example, the cervical spine, the maximum whole person impairment would be 80%. Thoracic spine, 40%, and lumbosacral spine, 90%. So in evaluating spine disorders, we obtain our measurements and our range of motions, as I've mentioned previously, using an inclinometer. And we assess and document the degree of movement across multiple planes. For example, in the lumbar spine, we would obtain range of motion and use an inclinometer to assess this motion in flexion, extension, right rotation, left rotation, right flexion, left flexion, to determine the range of motion in multiple planes. Then we would assess the DRE and look at previous diagnostic reports and previous surgery and factor that in to our impairment assessment for spine disorders. Okay, nervous system is a little different. Here we look at the central nervous system, brainstem, spinal cord, peripheral nervous system, and again, pain is part of our assessment and part of our integration into impairment. The central nervous system in particular, we have disturbances of consciousness and awareness, aphasia and communication disturbances, mental status and integrative functioning abnormalities, emotional or behavioral disturbances, types of preoccupation or obsessions. All these factor into our assessment. Again, we can't measure range of motion on anything in the central nervous system, so we must look at some of these other entities and use to assess to determine what percent impairment we're seeing. In addition, if there are major motor or sensory abnormalities, and that's to determine on the neurologic assessment of our physical exam. Movement disorders, episodic neurologic disorders, and then sleep and arousal disorders. All these are used in assessing the central nervous system to help determine impairment. So, our exam then focuses on the sensory examination, motor examination, and cranial nerves. Those are the things we can actually evaluate and measure during our physical exam. Now the brainstem, a little different. Here we have the midbrain, the pons and cerebellum, and the medulla. All right, so we need to take into account some of the factors and associated conditions associated with those. Again, spinal cord, looking at gait, the use of the upper extremities. Is there paralysis? Is there hemiplegia? Okay. Respiration. How's the respiration affected by a spinal cord injury? Is there involvement of the urinary system or bladder? Is there dysfunction? Okay. Can the patient urinate on their own? Are they able to control their bodily functions? Is there anorectal dysfunction? How's their sexual functioning? All these need to be assessed via history and sometimes a physical exam and sometimes other types of urodiagnostic testing to look at the effect of these conditions on the spinal cord impairment. Peripheral nervous system really looks at more of the spinal nerve roots and peripheral nerves. Okay? So here we have pretty much the same type of scenario. We can't necessarily measure movement or motion or range of motion in the peripheral nervous system, but we look at how the nervous system is functioning. Again, there are three main groups of fibers in the peripheral nervous system, and there can be impairments due to disorders of the peripheral nervous system because of an abnormality or involvement of these fibers: sensory fibers, motor fibers, or autonomic fibers. So our neurologic evaluation then looks at the loss of function of a body part due to deficits then in the sensory system, the motor system, pain, or even discomfort. All right? So there's loss of motor strength, loss of muscle tone, loss of the ability to control specific muscles or muscle groups. This is determined in our neurologic evaluation, and this is part of our assessment of impairment of the neurologic system. Okay? There can also be an alteration of the autonomic nervous system, and we take that into account as well. So our documentation in our report then should include descriptions of the spinal roots, the portions of the plexus and peripheral nerves that are involved, and oftentimes this is helpful by performing EMG nerve conduction tests to help with that assessment. So in evaluating the pain from a neurologic standpoint, we rely on the patient's description of the pain. What's the nature of their pain, the intensity, location? Again, pain scales are very helpful in assessing and determining the extent of pain. So often we'll ask patients to rate their pain on a pain scale. All right? And then we verify the anatomic distribution of the neurologic deficit. We verify the dermatomal distribution. As I mentioned, a lot of times we can do neurodiagnostic testing, electrodiagnostic testing, EMGs, nerve conduction studies, and sometimes even radiographic studies, blood studies, other types of diagnostic tests can be helpful in looking at the neurologic evaluation of pain. And then finally, we comment on the effect of the pain and the effect of the disorder on patients' functioning and the ability to perform activities of daily living. Now, we also focus on motor deficits. Okay, here, is there paralysis or weakness of the muscle groups? Okay, sensory changes can occur, and sometimes if there's a motor weakness, that will affect a sensory change. All right, and then strength assessment. The movement of the body part is tested against the examiner's resistance. All right, you can also test the body part movement and strength against gravity or without gravity. Okay, or in addition to gravity. All right, so again, assessing strength is very important. What is their strength? How has their strength been affected? What is their motor deficit? And again, part of our nervous system assessment. Finally, the autonomic nervous system. Again, the autonomic nervous system influences functioning of many of the organ systems in the body. So neurologic conditions that have an ANS involvement could include things like polyneuropathy, Guillain-Barré syndrome, syringomyelia, porphyria, cord and brain tumors, and myelopathies. All these types of entities may affect the autonomic nervous system, cause some system dysfunction, and contribute to an impairment. So how do you assess that? What are the signs of autonomic nervous system failure? Lack of control of blood pressure. Patients' blood pressures are very unstable, very brittle, very volatile. That could be a sign of ANS failure. Loss of the ability to control their temperature, loss of body thermal regulation. Again, sign of a failure of the ANS. Loss of control of bowel or bladder elimination is another sign that there may be some dysfunction in the autonomic nervous system. Okay, so we've talked about central nervous system, musculoskeletal system. What about pain? I mean, pain is a big part of patients' visits to the physician. All right. Almost every patient that comes in has a complaint of pain. How does this pain affect their impairment and hence their disability? Well, patients have complaints of intractable pain. The pain's always there, it doesn't go away. All right. There can be a lot of causes for this chronic intractable pain. Could be causalgia, or what we used to refer to as reflex sympathetic dystrophy, RSD. Now we talk about sympathetic mediated pain. It's pain caused from a dysfunction of the nervous system. Okay? Migraines, another very common cause of intractable pain that often needs to be addressed and assessed in relation to an impairment or disability. Cardiac conditions like angina, or even something as simple as a calcaneal spur, a heel spur. All these conditions can cause intractable chronic pain and again can have an effect upon impairment and disability assessments. Now, we can take this further and look at all the different body systems. I don't want to go through each system together, but I will highlight some of the more common systems that are sometimes assessed and we need to assign the impairment rating to. One of these would be respiratory system. Again, a lot of this is determined by taking a history from the patient and then looking at the patient's personal habits and workplace exposures to potentially toxic substances. Is a patient a smoker? Does the patient work around asbestos? Okay. What other toxic substances are they exposed to on a frequent basis? These can affect their respiratory system and can end up with an impairment of the respiratory system. We often use a radiologic evaluation, x-rays, to help with this. And again, physical examination is very important. So the physical examination can consist of an exam, looking at radiographs, sometimes pulmonary function testing, respiratory assessment, arterial blood gases. All these are part of our evaluation to help determine whether there's a respiratory impairment rating that we need to either identify or relate back to an impairment or disability of the whole body. The cardiovascular system is another area that's very frequently affected by impairment. Again, heart, it could be aortic involvement. Is it the systemic arteries throughout the body or the pulmonary arteries as they may interact with the lungs? Okay? The hematopoietic system, okay? Components of the blood, red blood cells, white blood cells, platelets, often patients that may have blood disorders. Okay? Again, they could have an impairment of that particular organ or system based upon the underlying condition. These disorders can be hereditary or acquired, and they don't necessarily imply impairment, but they can certainly lead to impairment. And again, sometimes we're asked to comment on this. Now, there are dysfunctions associated with the respiratory dysfunction, dyspnea, cough, wheezing, tobacco use, occupational histories. All these come into play and can certainly contribute to impairment. There are also other systems for impairment, and I could go into, but I just want to mention them. Visual system, ear, nose, throat structures, digestive system, urinary and reproductive systems, endocrine system, skin, mental and behavioral disorders, and again, finally, pain. I like to come back to pain because pain is such a big part of what we see and what we evaluate every day. It's a very common complaint. It's a very multifaceted concept. And the problem with pain, the challenge is that it's subjective. Right? So to assign an impairment based upon pain has not really been well defined, and we try not to assign impairment just based upon pain. But sometimes pain can have an influence on our impairment and may have a bearing. But for the most part, in coming up with impairment ratings, we stick to range of motion, we stick to diagnostic testing, we stick to strength testing, sensory, reflexes, objective findings we can document, and they can be reproduced on physical exam. And sometimes we use things like pain or respiratory disorders or cardiac disorders then to tie in to help substantiate our particular impairment rating. So I've talked about the guides, and again, the guides to the evaluation of permanent impairment is the standard text for assessing impairment and disability evaluations. But the guide makes some assumptions, because there's many physicians performing impairment disability evaluation.